being here, and for the next 30 minutes I will talk to you about diabetes self-management education and support with a focus on nutrition. When Akif asked me to talk first time, he asked to talk about nutrition and the role of a dietitian in the field of diabetes care. However, I don't feel comfortable with isolating dietitians because dietitians work as a multidisciplinary team with nurses, physicians, pharmacists, and so on to deliver diabetes self-management education. So therefore, I will focus mostly on diabetes education and the role of a dietitian or nutritionist to deliver DSME. So before I talk about what diabetes self-management education is, I want to talk a little bit more about the world and environment of a person with diabetes, and then a healthcare professional perspective of it. So then later the DSME, diabetes self-management education, is going to fit in better. I use the word diabetes self-management education instead of diabetes education, even though it's a mouthful. DSME, diabetes self-management education, is because diabetes education does not have a self-management in it. Self-management means that a person with diabetes is responsible for his or her own management. So we call it diabetes education, that's all it is. We tell people what to do and then leave them alone. Versus if we call it self-management education, that means that we teach them or train them how to take care of their own diabetes whenever they're doing it. So what the patient's needs are. So before we educate the patient, we typically assess their needs. And the way that we do it from a perspective in US, kind of like Heather was talking about structured education. In US we use the word diabetes self-management education, but it's a model that is like structured education, but it allows us to provide 10 hours of patient education the first year upon the diagnosis, and then later we can provide 2 hours for the following years. So that gives us, those hours are within a very careful assessment, assessing patients' needs, providing treatment of care, which is almost like medication, and then also evaluating the progress. And if evaluating the progress indicates the changes indicates the need to change, then we make those changes. Despite of the fact that we have diabetes self-management programs, and we have many of diabetes self-management programs, we have probably about 5,000 at this moment that are ADA, American Diabetes Association recognized programs that provide structured, multidisciplinary approach to people with diabetes. Only a fraction of people actually attend those programs. So whatever we do, like a survey, which would be a statewide survey or maybe a system-wide survey, we don't do a countrywide survey because it's a big country with 50 states and things operate differently. But this is one of them, and you can see that only 40% of people who are recommended by their primary care physician to attend diabetes education, they attend it. So 40% of people, given the education is available, it's free, they don't attend it. So then 60% do not attend it. So we have this challenge, we call it an access challenge. So given that the services are available and people are not utilizing it, we as a profession of diabetes educators kind of look at it as maybe we don't market ourselves effectively. Maybe when we say to people, come for diabetes education, education might be a scary word for them because people who are 50 or 60 years old don't want to go back to school and being educated in their life or preached to. So we kind of look at the way that we increase the access of people to the diabetes education and also effectively market it. And we have a lot of different campaigns that include, for example, going to a physician's offices and then talking to the physicians and asking them to effectively market us. Not to say, go and see a diabetes educator, but instead, a diabetes education can make a difference. Go and see, let's say, Barbara, because she's going to help you with something. So we collaborate as a team to make sure that the diabetes education is not scary for those that would benefit from it. So it works by first assessing a patient needs one-on-one. So we meet with patients for 2 hours. And that assessment is being done by either a nurse, a pharmacist, a physician, dietitian, whoever is the provider. That means that when you're a certified diabetes educator, you can make the assessment of patient's needs, the person with type 2 or type 1 diabetes. And after that, we put people in group education. So we don't have an option of using our hours with people with diabetes one-on-one. So it's group education typically, and we provide 8 hours of group education. The reason that we prefer to use group education is because that element of a peer support. When we teach people what to do and how to do things, they ask us, how do you know? Do you have diabetes? So it's more like a textbook education, but if they sit with each other and they validate their own stories and their own perspective, they almost teach each other. So the group education is very effective because it's truly patient-focused, because we're focusing on their lives with diabetes, and then they're part of a decision-making and coming up with solutions for what works for them. And then after that, we need to document it, what the results of that assessment and education is, and then send it to the primary care physician. So we close the loop. So then primary care physician is supporting the goals of that person, and so we work as a team. So who provides diabetes self-management education and support? The reason that support was added is because, and it was added last year from American Diabetes Association as a standard, is because we know that diabetes self-management education, it doesn't happen just, once you educate somebody, they know everything they need to do for the rest of their life. It took somebody 20 or 30 years of very long, not healthy habits to get diabetes. You cannot just suddenly learn within 8 hours and know what to do with it and just reverse it. So it takes time to reverse those unhealthy habits. So as a result of that, once people are educated about diabetes education, we support them. We need to make sure that they have access to either support groups or commercial programs like Weight Watchers, or they are part of, let's say, get a journal or some form of education that would allow them to manage the condition, to be aware of the changes, what's going on in diabetes care, because just like people's lives with diabetes change, so does clinical intervention. So we want to make sure that people are connected to their own options that they have with diabetes. But diabetes education actually is provided by dietitians, psychologists, registered nurse, anybody who is a healthcare professional and who has done, to sit in to become a CDE, you have to sit in for an exam, and then you have to have a 1,000 documented patient care hours to sit in for that exam. So typically an average dietitian, it takes about 2 to 3 years every single day, see about 5 to 6 patients. So it takes a long time to get the 1,000 hours to get accredited. But at this moment in the US, we have 16,000 certified diabetes educators, which is not enough because we have a lot of millions of people who have to sit non-stop and see everybody non-stop in order to see them. But 16,000, and the challenge that we have is that our certified diabetes educators are aging. So majority of us are in 40s, 50s, 60s. So I'm very pleased to meet so many of you being students, and then introducing yourself to me has been a total honor, because you are really the future. And then if you already have a passion for diabetes, start getting involved in diabetes education. Observe your colleagues go sit in on a consultation that the nurse does, or a primary care doctor or pharmacist. See what others are doing, and then that would help you to find your own place within your profession. So as I mentioned, what is the difference between a diabetes educator versus certified diabetes educator? The primary difference is that anybody can call themselves a diabetes educator. If you provide any diabetes education, it's just a term. You can call yourself a diabetes educator because you advise people there, what to do about their diabetes care. Versus certified diabetes educators are people who have to sit in for that exam. and then they have to recertify it every 5 years in order to be certified diabetes educator. That's why you have this R, the register mark. Typically, I sometimes see people use that term without the R. That means that it's just a local term that they're using. But it's registered for US only. So another difference is the difference between medical nutrition therapy and nutrition education that is part of DSME. I want to show you, this is what DSME is, Diabetes Self-Management Education. The first thing that we do is we increase knowledge. So we want to make sure that people know what to do with their diabetes. As you all know, knowledge does not equal to behavior change. There's a lot of people that know a lot, but they don't do those things. With diabetes, the same thing. If you ask some of your patients, they know a lot about diabetes. However, that knowledge does not translate into a behavior change. So you see that on the other side, see my pointer? You see on the other side, anyhow, the blue thing, it's behavior change. So it shows healthy eating, being active, taking medication, monitoring, problem solving, reducing risk, and healthy coping. Those things mean that those are self-care behaviors. So as a result of diabetes self-management education, one of or many of those behaviors have to take place in order for a person to know what to do with diabetes. And then, for example, when we counsel the patient, nutrition education is part of it. And nutrition education can be provided by a physician, it could be provided by nurse, pharmacist, because it relates to healthy eating. Versus if you look back at this one, medical nutrition therapy can only be provided by registered dietitians, and it's a separate service. So in our case, we have a diabetes self-management program, and medical nutrition therapy is separate. That is why it is nice to be a dietitian, because we have more hours to work with patients and get billable time. And medical nutrition therapy produces its own outcomes, which are very positive. Like this is medical nutrition therapy provided by a dietitian for people with type 2 can actually decrease A1C by anywhere from 0.5 to 2, which is pretty powerful because 0.5 to 2 increments, it's kind of like a really good diabetes medication. And this is independent of people taking medication. So even they're taking medication, medical nutrition therapy can be as effective as another pill that they're taking. Also, you can see the energy intake. So if a person is seen by a dietitian, and this is for type 2 diabetes, they can reduce their caloric intake anywhere from 200 to 700 calories. That's a lot. And what's nice about medical nutrition therapy is because it's an isolated service, so we can really monitor what it does. So that's why when we think about nutrition education, we don't know how much reduction in A1C or hemoglobin A1C happens with nutrition education. However, with medical nutrition therapy, if provided the way that it should be, it can bring down A1C as much as 2 increments. So what are some of the most common meal planning strategies that are being used by diabetes educators that include dietitians? I think that the most common one that we use, especially at the beginning when seeing a patient, is timing of the meals. Sometimes I sit with the patient for 1 hour, and what we're doing is kind of like focusing on that person eating breakfast, because they're skipping breakfast. So trying to come up with strategies where they can have a healthy breakfast. So it's not necessarily old school of providing a patient with a meal plan and having them to follow it, but working with them on the individual basis, meal by meal. Also, we really focus right now on eating healthy foods. Instead of reduction or taking away food, we focus on adding something healthy. So instead of limit or avoid, because I don't even know what limit or avoid means. Like, how do you avoid a butter? You know what I mean? It's there, you're going to eat it. But if you say, use olive oil instead of butter, then you're giving them an option. So as a nutritionist or a dietitian, we always focus on giving people, telling people ideas that they can have, or the food that they can have, instead of telling them to avoid things. We also use portion control. Portion control is becoming less frequent just because it's people who are, let's say, overweight. Portion control does not always work because they're hungry. Because they're used to eating a lot of value, so you have them eating portion control, it's like they're hungry and then they binge later. So unless you have a healthy choices where we said, you know, have a big salad so you have a lot of volume or soup, so it's still the same amount of food that they're eating, but with less calories, that really works as well. Carbohydrate counting we use a lot mostly for type 1. For type 2 diabetes, we only use carbohydrate counting if let's say, if they need insulin to carbohydrate ratio, but it's very frequently used. A glycemic index not very popular in U.S. I have been a dietitian for the last 20 years. I have never had anybody who wanted to do glycemic index. And the reason for that is because the science is there, but the actual eating kind of thing, you have a watermelon, let's say, that is a high glycemic index, but you complement it with cheese, that really gets the math off. So glycemic index, I think that the biggest experts in glycemic index are in Australia. There's a lot of good research, a lot of advice, but in US, it's just not a very popular way of manipulating or adjusting the diet. But so those are some of our practical advices. We do not know what we're going to use with each individual patient until we see the patient. Because we have the patient make the decision. We're kind of making a very careful assessment, what they can do and what their health literacy level is, what their socioeconomic level is, can they pay for it, can they afford it, do they have access to the store. So there's a lot of different variables that are part of the decision making. So really, simplicity is the ultimate sophistication. Like what I typically do with my patients the first time I see them, many times I don't even prescribe any nutritional strategies for them. I ask them to keep a food journal for the next week or two. By them writing down what they're eating, they're self-realizing. They're looking at a paper and they're like, wow, I eat a lot. So so then I don't have to convince them and sit for 2 hours and tell them that they're eating too much if they kind of already know it. But the goal is for them to self-realize that when they see it on a paper and they see, I also have, why are they eating? Are they eating because they're lonely, because they're tired, or because they're watching TV? For them to kind of associate food with feelings, it all makes sense. So then I have a patient coming back to me telling me exactly what he or she wants to do. So my job is easier because they're making, they self-realizing what's going on with their own routines. So this is an example. Like if we have a McDonald's person, like I have a lot of people, because I work in Chicago, so we kind of have what's called food deserts. So that means that there are areas in Chicago, so when you tell people, why don't you, let's say, get a salad? Or why don't you walk? They don't have stores that sell salads, or they cannot afford a salad because they're on a limited budget, so the cheapest food is in McDonald's, let's say. Or the cheapest food is a cake, or stuff that has a lot of sugar and calories. So for those people, I cannot give them ideas about foods that they will never be able to have access to. So sometimes it's a very simple strategy. When you go to McDonald's, instead of Big Mac, have a smaller hamburger. Once they eat something smaller, but they have the choices within the environment, then they're able to later feel good about their decision making, lose a pound or two, then they have more energy, they feel better about themselves, and they're more likely to add additional healthy behaviors that are needed for them to acquire new behaviors. Because one positive creates another positive. So as soon as people start feeling better about themselves, they're able to add additional behaviors. Sometimes we don't even do nutrition changes to people's strategies. Sometimes we tell them just walk a little bit more. Walk 30 minutes every day. Once they start walking, they have more energy, they feel better, and they're more likely to make nutrition changes. So what are the existing evidence for diabetes self-management education? Over the years, it kind of has evolved from improving clinical care outcomes. We know that diabetes self-management education makes a difference clinically in the short term. So it improves outcomes in 3 months, up to 12 12 months. And then later, there's not too much studies that indicate that the investment that we made, let's say with 10 hours the first year upon of the diagnosis, does it have a long-term impact, like what happens 2 or 3 years after. So we know that diabetes education makes a difference in 1 year, we know, but not after that. We kind of evolved from a didactic teaching, telling people what to do, doing a session, big sessions, to more empowerment-based, where people are part of the decision-making, and it's a collaborative effort in what people are willing to change. And the group education is becoming a little bit almost like a global standard, because number one is there's not enough of us to provide one-on-one consultation, and number two, we know that the group education either can be as effective as one-on-one, or in some cases more effective. So it's a good strategy to do more people in a short time. And then ongoing support is critical to sustain progress, and behavioral goal setting, it's really, really good. What's interesting about the goal setting, I think that we have been doing goal setting for like 10 years. So like we have evolved from goal setting, like I remember when we were doing short and long-term setting, we were giving a patient a list of a behavior change, and we tell them, check the one that you want to do, like lose weight or exercise more. And people were just checking boxes because they wanted us to see that they want to be good patients. And now we have kind of evolved with open-ended questions. So instead of being suggestive to people, you know, what the goal is, we try to ask them, what are you going to do differently till the next time I see you? Or what are you going to do differently when you're going to come in, you know, for the next exam? And I tell you what's interesting, when I ask that question, many times I have patients to come back and I ask them, so what did you do differently since the last time we did a class? And many times they would say, nothing, but you were wonderful. You taught me everything. And I, educator, I feel so bad because I clearly didn't do everything because they were not able to implement anything. So a lot of times patients are doing a lot of things to almost please us because they want to be good patients. So being patient or learner-focused really kind of asks us to ask the right questions at the right time, so they are decision makers. So it's ultimately their decision. If it's their decision, they own it, they will do it. And even though it might not be what we want them to do, because they came in for nutrition consultation, but they're not willing to do anything but walk every 30 minutes, that's still fine, because that ultimately is going to get us to the goal of them to be more willing to do other things. So why are we doing all of this, a lot of different behavioral strategies and focusing on the patient's needs? As Heather has mentioned, it's because majority of the care for people with diabetes is done by a person with diabetes. And the reality is that it took them a long time to acquire those unhealthy habits, and it will take a long time to break them apart and also unlearn that. And a person with diabetes does not just live diabetes. They have their families, they have kids, they take care, provide care for their grandchildren or kids. They have a normal life. They have to go to work. So diabetes oftentimes, it does not take big priority. And the reality is, if we know that more, I think somebody said that more women have diabetes than men. They're typically a family takers, so they take care of their family. So oftentimes they will neglect their own needs to put their kids first or their family first. So it takes a lot of effort to really provide that care. There is also a lot of challenges for healthcare professionals. Our systems are not really designed for chronic care model. They're more acute care. You get sick, you get antibiotic, you're being sent home. It's more like adherence based. You take your medication, things get better. With chronic disease, such as diabetes, it's not like a one pill you take and things get better. It's just a lot of different things that you have to do over a period of several years to see the impact of clinical improvement. So also patient exposure to a primary care physician in US, unlike UK, it's only less than an hour. So the physician only sees patients for less than an hour within 1 year. So it's a very short amount of time that he or she has. So that's why we rely on diabetes educators to provide us kind of services. And then another thing to keep in mind is poor functional health literacy. What that means is that people don't understand what sometimes we tell them. When we use big terms like hypertension or lipids or glucose, we often provide a lot of different details about the things that people don't understand. And health literacy, what's interesting about health literacy, it's actually independent of education level. So you can have somebody with PhD, but that person cannot apply that information in real life. A friend of mine got braces, and she's super smart, like she's a PhD, like knows things, and then she got confused because she was told that she's going to wear those things on the teeth that are permanent. The word was permanent. So she was convinced that she's going to wear those things for the rest of her life. But the word permanent meant for the duration of wearing the braces. So it's sometimes the words that we use can be misunderstood by patients, and consequently their behaviors are negatively impacted by it. So this is interesting because this is some of the statistics when it comes to what really people remember from interacting with their primary care doctor. So patients forget 80% of what the doctor tells them. 80%. So they only remember 20% of things. And then nearly 50% of what you remember is incorrect. So out of the 20% they remember, 50% they remember wrong. So 10% of your time spent with a patient might be only applicable. So it's kind of think about effectively strategizing what you say and how you say it and when you say it to people in order to make sure that they understand you. You probably have used and applied or heard of a teach-back method. Teach-back method is asking your patients to explain to you what you just told them. I ask them, if you would have to explain diabetes to your 5-year-old, how would you explain diabetes to your 5-year-old? Or I would say, okay, I just spent 10 minutes telling you those complex things. Could you summarize what you heard me say in your own words? Because I want to make sure that you understand what I just told you in your own words. And oftentimes I'm like, that's not what I said. But I do it in my head, of course. But my point is that a lot of times people don't, like in front of you, they just repeat what you just said, and they totally interpret what you just told them differently. So teach-back method is very practical. It takes a short amount of time. Just ask them, could you summarize everything that you heard me say right now? Very effective, and that way you will know what they know. So some potential solution is really a shift from more didactic to more empowerment model. So time spent offering recommendations that are not being implemented or understood is time wasted. So like in US we have to kind of convert everything into the dollar, how much it costs to do things. So it's really, if you spend a lot of time and know that only 20% of that information is being retained, then we have to think about how we can maximize our time so more information is going to be retained. And also avoid miscommunication by finding the right words to say at the right time. And put systems in place that you're evaluating outcomes. And those systems in place are very easy. Like either you can do it with hemoglobin A1C to see which provider produces better hemoglobin A1C, or weight loss, or patient satisfaction, and so on. So one of our biggest systems in place to make sure that we collectively deliver effective diabetes healthcare management or chronic condition management is chronic disease model. It has been around for a very long time, but what it really involves is communication, not just between a healthcare provider and the patient, but also healthcare provider between healthcare providers. So then, like for example, what I say to a patient as a dietitian, then that physician can loop around and support the same thing. So we talk the same language. So it's not like I say this person says that, so then patient gets different information from different people. It's making sure that healthcare providers talk about that specific patient or the case studies, so we are communicating consistent information to a person. There's a new model that has been in place, and it's kind of more user-friendly than chronic disease model because it's easier to implement. It's called the patient-centered medical home. And like, I work in Chicagoland, and we have probably about 40 hospitals, a lot of hospitals, and I don't know one hospital that doesn't use this. But patient-centered medical homes, especially now with diabetes care, clinical care that needs to be individualized based on the patient's needs, this model works really well because you can see on the bottom, in the green, where the grass is supposed to be, it says capacity and accountability. And the capacity and accountability is both for the healthcare professionals and a person with diabetes. So on the top, you have a whole person orientation, where we focus on the whole person, the family, what the patient is capable of doing, not just of what our needs are to educate them. And then safety and quality and care coordination and enhanced access to the care. I'm going to skip that because Heather already talked about this. What we're doing with our patients when we provide diabetes self-management education, Heather has mentioned this, but it has kind of evolved to making sure that we use like different theories, to make sure behavioral theories, but it's not just, oh, I just came up with a PowerPoint and I'm just going to use it for my patients. It has to be based on evidence-based. So that communication or those approaches you have to know that they produce the outcome. So many times when we use what's called situational problem solving, and situational problem solving would be, let's say, instead of giving the patient an instruction on how to store insulin, where it says, you know, you put it in the refrigerator, if it's not used within 60 days or 30 days, you throw it out. We don't do that anymore. What we do is say this: when it's very hot outside and you left your insulin in the car and you come back and now it has a cloudy look, what are you going to do with it? So we create a situation that can happen within a person's daily routine, and they have to think through what the solution is. Because when you give people instructions, people don't use instructions. People use situation and solution making. So situational problem solving is used like 70% of the times by us. Also, we do cognitive reframing, patient contracts, and conviction and confidence scaling. I like confidence scaling because it can allow us to quantify our behavior change. By that I mean on a scale of 1 to 10, how confident are you that you can do it? And they would say, I'm 7. So then you can say, what can we do today to bring you to 8? And then later you document it, and then next time you see the patient, you ask them, so you were 7 before, where are you now? And what surprises me is that sometimes their confidence level actually goes down. And the reason for it is because they were good for a week or two, their confidence was really good, they were doing so great, and then 2 weeks after they relapsed. So that's why it's important when you think about follow-up with your patients not to wait too long in between visits. Like people sometimes wait 4 weeks or 5 weeks. And then people are typically good with their new behaviors for like 2 weeks. So you want to catch them when they're good, because then they feel good about that, and you add additional good behavior, and then good creates good, and so on. And then many times, because they have relapsed 4 or 5 weeks after, that's also part of the reason the patients do not come back, because they don't want to come back and tell them, I didn't do that great. You know, I have failed with my goal setting. So when you think about scheduling appointments, think about strategy, how long you want to wait between appointments. So that's going back to the teach-back methods. You want to make sure that people can explain in their own words what they heard you say. So it has to be very simple. How many of you have seen stages of change before? With frequent stages of change. Stages of change has been around for a very long time. And with behavior change, it's a great tool to assess people's willingness to change behavior. And we use it a lot not because when we know that we kind of know that they're in denial or maybe not interested, they're not in action state. Not because of that, but because of the last column, what you can say and do to help people. So for example, if they're in pre-contemplation, that means that in the total denial, they don't even believe that they have diabetes. So those are the patients that are like, I'm here because the doctor told me that I should be here. I'm like, well, it's because you have diabetes. And the response is like, no, I don't have diabetes. And the hemoglobin A1C is 10. So the people who are in denial,
it's not a very good thing to tell them what to do, like how to eat and exercise and other things. So when people are in denial, you want to support feelings, you want to make sure that you validate how they feel and why they feel that way and so on. So those stages of change are very practical because they help us to effectively communicate with a person with diabetes. And usually to get a person from one stage to another, so let's say if they're in the preparation, so they're like, I'm willing to make this behavior change, I'm willing to lose weight, but not this week, but I can start next week. Typically the process takes anywhere from a week to 3 months. So that I am willing to do it, typically it's not right now, it takes several weeks to get there. And then the last part, when you can see the stages of change, which is the relapse. What's interesting about relapse and diabetes care is that what we know now, that people when they're at 12 months, so they're very good with their hemoglobin A1C, they're good with their clinical care outcomes, so they're like a perfect patient. When they're a perfect patient for like 12 months, think about relapse, because they're perfect, but life changes. As life changes with their diabetes, they also need to, and then also routines sometimes get boring, so people need change. So it's kind of looking into to make sure that, that we provide them with strategies that can be either modifying the routine to continue the existing change. And also, as you know, diabetes is a chronic condition, so even though they continue to eat healthy foods and so on, it kind of, the beta cell production, insulin resistance, all of things, so then your glycemic control goes down. So the relapse is an important component to look into. So how close are we in achieving optimal care outcomes with people with diabetes? And this is very new. I just got it because it was published in February 2013, so this is new data. In US, A1C, hemoglobin A1C, we're at a little bit over 50% target range. Blood glucose is a little bit over 50, LDL is 56, but see the bottom of it, the ABCs of diabetes care is only less than 20%. So the reality is that even though, let's say, A1C could be at 50%, but the other clinical care markers that really make people live healthier and longer lives are not achieved, because less than 20% is not that great. So what we were trying to do as a nation is we have what's called a healthy people, and it changes every 10 years. So as a nation, we have different strategies to make sure that our population is healthy, and then as a team or as a systems, we build systems to really guide us to that goal. So we have like a Healthy People 2010, we used to have, now it's Healthy People 2020, and it relates to, let's say, smoking cessation, relates to healthy eating, relates to infection control and other things. But we also have a diabetes component of it. And you can see that our baseline in actually getting and receiving or seeing the diabetes educator is at 56% nationwide. So it's less than 60% right now. And our target by 2020 is to make sure that at least 62.5% of people with diabetes get to experience diabetes education.
Barbara, may I kindly request you keep closer to the microphone so that the translators will be easy for them to...
Thank you. I will do that certainly.
Thank you.
So those are our goals. So those are national goals. And even though they're very minor, but they're significant enough because I mentioned before, we're a big country with 50 states with different systems in place. So if we get over 60, so I think in some schools, 50 something, that's an F. If we get to D, we'll be happy. At least we're going in the right direction. So I kept my promise. I kept it below 30 minutes. So kind of in conclusion, what I would want to say is that diabetes self-management is really a multidisciplinary intervention. So diabetes self-management, dietitians are part of the team, but in order for us to work effectively, it's a collaborative effort with physicians, nurses, pharmacists, as a team, because we cannot do it on our own because there are so many different self-care behaviors. And nutrition is only one of them that need to take place in order for a person to make changes in their behaviors. It works by careful assessment and also ongoing process. So the more time you see the patients, more contact with patients, the better outcomes. throughout their course of living with diabetes. And it's provided by a multidisciplinary team, and the outcomes are really positive. Remember what I was telling you, that medical nutrition therapy is as effective as the medication. It can decrease A1C by anywhere from 0.5 to 2 increments. It's a pretty powerful tool. So nutrition intervention, or MNT, could be a pill. It's as effective. So is diabetes self-management education. It works that way if implemented appropriately. That means by the right healthcare professionals who are competent in that delivery, and also they feel confident that they can do it within that specific scope of practice. So to summarize, I want to really thank you for staying longer today. I know that my talk was at 3 o'clock, so thank you for being here.